All right, today we are stepping into the role of medical detectives. We're going on a diagnostic journey, following the clues our own bodies leave behind to figure out why some people bruise or bleed more easily than others. This is all about how lab tests help us decode that puzzle. It all starts with something you've probably seen before, an odd bruise, maybe a cut that just doesn't want to stop bleeding. Well, that's your body's first responders, your platelets, sending up a little flare. These tiny cell fragments are basically in charge of plugging leaks, and when they're not working right, the signs they often show up right on your skin. So to solve this puzzle, we first have to know what we're looking for, right? It all boils down to the most important job that platelets have, stopping the bleeding. And when that process breaks down, well, that's when our investigation really begins. And here's the first concept we need to grasp: primary hemostasis. It sounds technical, but it's really just the body's first line of defense. When you get a cut, your platelets rush to the scene, they stick to the injured area, and they clump together to form a temporary plug. Think of it like an emergency patch that buys your body some precious time to make a more permanent repair. Our investigation now splits down two main paths. It's like a fork in the road. On one side, we have a quantitative question. Is this a how many problem? Do we have enough platelets, or maybe too many? And on the other side, we have a qualitative question. Is this a how well problem? We might have plenty of platelets, but are they actually doing their job correctly? So let's start with the most basic question you can ask. We have to do a head count. The very first step in the lab is always to find out if the numbers are right. And here it is. This is the magic number. If a patient's platelet counts drops below 150 billion per liter, we call that thrombocytopenia. That's just the medical term for having too few platelets. Once you dip below this number, your body just might not have enough of those first responders to form that critical plug. This really lays out both sides of that how many problem nice and clearly. You've got thrombocytopenia, which means too few platelets, but on the flip side, you've got thrombocytosis, which means way too many. And that can cause its own set of issues, like unwanted clotting. So it's clear the body needs that platelet count to be, well, just right. But what happens if the count comes back totally normal? The numbers are fine, but the bleeding problems are still there. This is where our investigation takes a turn. We pivot from asking how many to asking how well. And our main tool for this next phase is something called the platelet function assay, or PFA. Now, this isn't just counting platelets. It's more like a performance review. It's a screening test designed to see if the platelets are actually up to the task when they're called into action. So how does it work? It's actually pretty brilliant. The PFA basically mimics an injury inside a tiny tube. Blood flows through this little tube that's coated with things like collagen, stuff platelets would normally find at a wound. The test then times how long it takes for the platelets to get activated and form a plug that stops the flow. We call that the closure time. And if that time is too long, well, that's a huge clue that something's wrong with how they function. Now, if that PFA screening test comes back abnormal, we need to dig deeper. It's time to bring in the advanced forensics. A platelet aggregation test is going to give us a much closer look at exactly what part of the process is failing. This test is all about controlled stimulation. We take a sample of platelets and we add very specific chemicals to it, called aggregating agents. Each one of these chemicals is like a key designed to trigger a different part of the platelet's machinery. By seeing which chemicals make the platelets clump together, or aggregate, and which ones don't, we can start to pinpoint the exact problem. Let's start with our first key agent, ristocetin. This one is super specific. It tests whether platelets can properly link up with a protein called von Willebrand factor, or VWF. You can think of VWF as the molecular glue that helps platelets stick to an injury. So if platelets don't respond when we add ristocetin, we know there's a problem with that very specific connection. And then we have our other agents, like ADP, collagen, and epinephrine. Each one of these tests a different receptor on the platelet, a different lock, you could say. If ristocetin was the key for the VWF lock, these are the keys for all the other locks that are essential for platelets to stick to each other. So, by trying all the different keys, we can figure out exactly which lock is broken. Okay, we've gathered all our evidence. We've got the count, we've got the closure time, and now we have these aggregation patterns. Now it's time for the payoff. Let's see how these lab results create a unique fingerprint that lets us identify specific disorders and, finally, solve the case. So here's our first case file, Bernard-Soulier syndrome. Looking at the data, the PFA closure time is increased. meaning that plug takes too long to form. And, most importantly, platelet aggregation is abnormal, but only with resticetin. And that right there gives us our first fingerprint. See, in Bernard-Soulier, the platelets are literally missing the receptor for that von Willebrand factor glue we talked about. So it makes perfect sense that the only aggregation test they fail is the one using resticetin. That specific failure, along with seeing giant platelets under the microscope, points us straight to the diagnosis. It's a true aha moment in the lab. All right, next case, Glanzmann's thrombasthenia. Once again, we see an increased PFA closure time. But look at this. This time, the aggregation is abnormal with ADP, collagen, and epinephrine. That's a very different pattern. The fingerprint for Glanzmann's is almost a mirror image of Bernard-Soulier. In this case, the platelets have the receptor for VWF, so they aggregate totally fine with ristocin. But they're missing a different receptor, one they need to link up with each other. And that's why they fail all the other aggregation tests. And finally, let's look at the most common inherited bleeding disorder out there, von Willebrand disease. Here, the PFA closure time, well, it could be normal or increased. And just like in Bernard-Soulier, we see abnormal aggregation with ristocin. So how on earth do we tell these two apart? The key to the von Willebrand disease fingerprint is looking at a few extra clues. See here, the problem isn't with the platelet itself. The platelet is perfectly fine. The issue is a lack of that VWF glue protein in the blood. Because the glue is missing, the platelets can't stick properly, so they fail the ristocin test. To confirm it, we run other tests that actually measure the amount of VWF protein, and that seals the diagnosis. So there you have it. From a simple count, to a performance review, to a complex aggregation pattern, each lab test builds on the last. It allows us to go from a general symptom like easy bruising all the way to a precise molecular diagnosis. These tests really do turn abstract data into concrete answers, solving these little medical mysteries one blood sample at a time. Makes you wonder, what other secrets are our bodies waiting to tell us if we just know the right questions to ask?